Hypo and hyperpituitarism. As you know, the pituitary is located in the brain and is responsible for secreting many important hormones that help with growth and development, mainly HGH, the human growth hormone, among others. Now, I call them the testicles of the brain, since they kind of look like testes, and they're responsible for the hormones of the body, just like the testes. So for hypopituitarism, the patho is simple. Hypo, think low, low amounts of growth hormones. So low hormones are produced, so our clients present small and frail. Now for signs and symptoms, clients will present short in stature. So Hesse mentions common clinical manifestations of hypopituitarism that occur due to deficiency of growth hormone, short stature. And Kaplan, hypopituitarism, clinical manifestations, short stature. Now causes, a tumor in the pituitary gland is the main culprit. And for diagnostics, a CT scan or a CAT scan checks for the tumor among other pituitary gland problems. And for treatments, we know that these clients have low hormones with hypopituitarism. So we just replace the hormones. Like growth hormone, corticosteroids helps to replace the steroid hormones, and levothyroxine helps to replace the thyroid hormones, as well as testosterone and estrogen replacement. So Kaplan mentions the most commonly prescribed hormone for a preschool client with idiopathic hypopituitarism is growth hormone. Now switching gears to hyperpituitarism. The patho is simple. Hyper, think high amounts of growth hormones. So our clients present big and tall like a big giant. Now this condition is actually called gigantism, with excessive growth or acromegaly, as well as presenting with enlarged hands and feet. So for the signs and symptoms, Hesse mentions which assessment findings for hyperpituitarism: overgrowth of the long bones, thickened, deeply creased skin, and malocclusion of teeth, and an enlarged jaw. Now for the causes, it's caused by non-cancerous tumors. So for the treatment, we just remove the tumors. That's it. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and
Pablo is a 32-year-old male presenting with a blood pressure of 145/95, ST depression on the cardiac monitor, serum potassium of 3.1, and complaints of frequent urination during the day. Oh snap! What could be wrong with Pablo? And what priority nursing interventions do you need to know for the NCLEX? I'm Nurse Blake, and today we're talking about hyperaldosteronism, which is what happens when there is too much secretion of aldosterone, aka aldosterone. He's our security guard bouncer of the kidneys. We'll call him Al for short. He adds sodium and water into the body by not letting it leave the kidneys, which makes the blood pressure go crazy high. And L for lets potassium out of the body and into the potty, which causes low potassium, aka hypokalemia. In fancier medical terms, hyperaldosteronism, also aldosteronism, is a medical condition where the adrenal cortex secretes too much aldosterone hormone, which can lead to lower levels of potassium in the blood, hypokalemia, and increased hydrogen ion excretion, alkalosis. Now, we also call Al our saltwater hormone to help students differentiate between aldosterone and ADH, the antidiuretic hormone, a totally different hormone that keeps water in the body and not in the potty. Okay, so let's do a quick review of normal adrenal physiology. As you know, the adrenals sit on top of the kidneys and help the body adapt to stress by using MAC hormones. Just like Mac computers, the adrenals look like the Apple logo. So remember the acronym MAC. M stands for mineral corticoids, like aldosterone, aka aldosterone, our steroid hormone, security guard bouncer to the kidneys, in the renin-angiotensin-aldosterone system. Again, remember Al. He adds sodium and water in to balance blood pressure, and L lets potassium out of the body and into the potty. Next is A, for androgen steroids to help with hair and sex. And our first C is for cortisol steroid, our very famous stress hormone. Lastly, C is for catecholamines, epi and norepi, also called adrenaline, our fight.
Subhanallah.
So now that we reviewed the basics of normal physiology, what's going on in hyper-al? Well, we have high aldosterone, right? So the ability to add sodium and water into the body is super high, which leads to hypernatremia and hypertension. And the loss of potassium is greater. So hypokalemia sets in, and we get a higher pH level as the body loses more hydrogen ions in the urine. This is called metabolic alkalosis. So we will see complaints that all stem from high al, high aldosterone. Again, our main sign and symptom, think high al. A for add sodium in water, so we get hypernatremia over 145, and hypertension, a blood pressure of over 140 over 90. L is for loss of potassium, resulting in hypokalemia, a potassium level of 3.5 or less. Now, our main sign for hypernatremia is polydipsia, extreme thirst, a swollen, dry tongue, and increased muscle tone, which is a huge NCLEX tip. And our big symptoms for hypertension are headaches and facial redness, also called flushing. Now, for hypokalemia, our low potassium of 3.5 or less, everything will be low and slow. So our heart monitor will show ST depression and prominent U waves. So remember, anyone with low potassium, we always put them on a heart monitor. This is the first thing we do as a nurse. I can't stress that enough. It's always a big priority. As far as the muscular system, it will be low and slow with decreased DTRs, deep tendon reflexes, and lastly, GI will be low and slow with constipation and hypoactive bowel sounds. Okay, now for the weird signs and symptoms. Patients get both polyuria, which is frequent urination, and diluted urine, which is a low specific gravity of less than 1.005. So to help you remember this for your next test or the NCLEX, use the acronym HYPER-AL. H for hypertension, a blood pressure of over 140 over 90, and Y is for yielding, or slow DTRs and vowel sounds. P is for polyuria and polydipsia, excessive urination and thirst. E is for ECG, and this will show you waves in ST depression from the low potassium of less than 3.5. And again, the first action is to always put this patient on a cardiac monitor. The patient's heart can stop with low potassium, so do this first. R is for raining urine, a low SG of 1.005. A is for adding sodium, a sodium level of over 145, and L is for losing potassium, 3.5 or less. Okay, so now what are the causes? Well, it can occur because of primary causes, like those inside the adrenals, or from secondary causes, outside the adrenals. Okay, let's start with the primary causes. Now, it's usually idiopathic, which means we don't know why it's caused. Idiopathic means we're idiots to the pathology. But a big cause is usually from Conn syndrome, where a non-cancerous tumor grows inside one of the adrenals. This makes the adrenal overproduce hormones. So we see that little white dot right there? This is our little tumor. Lastly, family genetics can play a role, meaning it runs in the family. This can cause high blood pressure in children and teens. Now switching over to secondary, it's caused by things outside the adrenals. This happens in congestive heart failure, where the renals receive less blood flow due to less cardiac output from the heart. This low oxygen to the kidneys forces our kidneys to think the body has a low blood pressure. So the kidneys react by releasing the dominoes into activation of the RAS system, the renin-angiotensin-aldosterone system. This keeps water and blood pressure up, but we are left with too much aldosterone. Our last common cause is from the renal artery stenosis. This is where the narrowing of the kidney tubes results in less blood flow to the kidneys. And again, the kidneys think the body has a low blood pressure. So again, more renin gets produced and the cycle of RAS starts all over again. So now our labs help to pinpoint the cause. So in primary, we'll see low renin and high aldosterone, like in Conn syndrome, when a tumor of one adrenal is secreting the high aldosterone. So the body turns off renin, but we still have high al. And in secondary, we see both high renin and high aldosterone. Like in heart failure or renal stenosis, the body thinks there is a low blood pressure. So high renin production turns on the RAS system, which produces both high renin and high aldosterone. So now that we know what is wrong with our patient, what are we going to do about it? What's the main goal? We need to lower that aldosterone so we can lower that fluid volume and raise that potassium. This is our priority, since fluid volume overload can impair airway and breathing. So we give potassium-sparing diuretic, and these guys end in actone, like spironolactone. Remember that diuretics make the body diurese fluid, meaning making you pee. And usually we lose potassium during urination, because where fluids flow, electrolytes go. And you know, where fluid flows, electrolytes go! Well, not in this case. Spironolactone is a potassium-sparing diuretic, which helps keep potassium in the body and not in the potty. So, we call spironolactone the special hitman that targets and deactivates aldosterone directly. Lastly, if all else fails,
Subhanallah.
which is causing the problem. Pretty simple, right? Wrong! Cutting off an adrenal can cause an Addison's crisis, where we have no MAC hormones to keep the blood pressure up. This means no blood pressure stability and can lead to hypotensive shock, meaning blood pressure so low that it can actually kill the patient. Now, we go over all the treatments for this crisis in our Addison's video. But just for the test, please know that removing a kidney or an adrenal can cause this crisis and kill your patient. All right, guys, that wraps it up. Thanks so much for watching.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download.
Maria is a 74-year-old female presenting with complaints of diarrhea 3 times a day, muscle spasms, and tingling of the lips and fingers. She has a history of thyroidectomy and osteoporosis. Upon reviewing her labs, the nurse finds serum calcium level of 7.2, potassium of 2.9, and a sodium level of 125. Oh snap, what could this be, and what are we going to prioritize as a nurse? What's up, guys? I'm Nurse Blake, and today we're wrapping up both hyper and hypoparathyroidism. They are those little round button-looking glands that sit on the back of the thyroid near the neck. These little dudes can cause so many problems with calcium, but we'll cover that in our patho section. So let's break down the terms. Hyper means high, and hypo means low. Para means alongside, and then thyroid means, well, thyroid. So hyper anything always means overactive, like a hyper person. And hypo is the exact opposite, underactive, like a super boring person. The parathyroid glands are almost exclusively responsible for the regulation of blood calcium. So think PC, like a computer. P is for parathyroid, and C is for calcium. And the levels are typically 9.0 to 10.5. However, some books will say 8.5 to 10.0. So be sure to know what your textbook says. The main point is the calcium, guys. If the parathyroid hormone is high, that means calcium is high. And when the parathyroid is low, what is the calcium? Yes, low. So hyperparathyroid means hypercalcemia, and hypoparathyroid means hypocalcemia. That's why I remember PTH, the parathyroid hormone. As an acronym, PTH puts the calcium high. Think of a thermostat or a light switch. This is called our negative feedback loop. When calcium's high, PTH shuts off. And then when calcium's low, PTH turns on. But remember, PTH puts the calcium high in the blood. Now, how does it do this? Calcium is increased in the blood by 3 ways. So remember the acronym RIB, R-I-B. R is for renals, which reabsorbs calcium, so it's not lost in the body. I is for intestines. They help to increase blood calcium by absorbing it from food, and the help of vitamin D activation. This is a big tip right here, guys, so please write this down. Both calcium and magnesium love vitamin D, and they all work together. So you'll often see calcium, magnesium, and vitamin D all in the same multivitamin. And B is for bone, since our hard bones are made up mostly of calcium. And when your body needs more calcium, it usually drains the bones to get it. So with too much PTH and hyperparathyroidism, there is too much calcium in the blood. It's like every organ is being squeezed for their calcium. Like PTH is the bully, taking all their lunch money. Remember, PTH puts the calcium high, so blood calcium goes up, right? So we have stones, moans, and groans. Stones in the kidneys, moans from broken bones, and groans from rock-hard bowels. So PTH makes bones weak by taking calcium from their storages. This makes them brittle, meaning a big risk for fractures. Okay, so the kidneys, the washer machines of the blood, have to filter out all that excess calcium from the body and into the potty. But they get overloaded, and we get kidney stones, aka renal calculi, from all that overload of calcium. And lastly, our GI, Mr. G.I. Joe. Our intestinal tract gets overloaded with calcium, causing rock-hard bowels, a common sign and symptom of hypercalcemia, too much calcium. Okay, so remember, the top 3 signs of hypercalcemia are usually stones for kidney stones, moans for fractured bones, and groans for constipation. So guys, again, for hyperparathyroid, remember, hypercalcemia. Everything is swollen and slow with high calcium. And for hypoparathyroid, that means hypocalcemia. Remember Baja California from low calcium. And as you can see, we used our electrolyte emoji, Mr. Cocky Calcium, from our electrolyte course. Now the signs and symptoms are so easy, right? Because hyperparathyroid patients will look exactly like hypercalcemia patients with stones, moans, and groans. So let's review the top 3 most tested signs and symptoms. Let's play it here.
And up next, we have Cocky Calcium from Muscle Beach, California. Because calcium Ca kind of looks like California Ca. Calcium's main function is to keep the 3 B's strong: bones, blood, and beats. Blood for clotting factors and beats for heartbeats. So hypercalcemia, everything is going to be so swollen and slow with moans, groans, and stones. So constipation from a swollen and slow GI, bone pain because calcium's leaving the bones and going into the bloodstream. We'll also have kidney stones called renal calculi, as well as deep tendon reflexes will be swollen and slow. So decreased DTRs and severe muscle weakness. Okay, now next is hypocalcemia. Now, this one's a little bit fun because Cocky Calcium goes to Mexico, Baja California. So he learns 2 new dance moves, so write this down. Travassiers, which is basically that arm twerk with a blood pressure cuff on. And also Shavak sign, basically the smile when you're stroking the cheek. Guys, those are the 2 biggest ones for your next test, so write those down. He'll also have diarrhea, so just think he had bad burritos in Mexico. And lastly, circumoral tingling, basically tingling around the mouth.
Okay, so now what are the causes? For hyperparathyroid, that means hypercalcemia, and we use the acronym Dr. T. D is for decreased calcium absorption. Again, the body thinks, crap, we have low calcium, better go into hyperdrive and get more calcium into the blood. And this happens because of low oral intake of calcium, low vitamin D intake, because remember, vitamin D helps calcium absorb. Another cause is malabsorption, and this happens when we don't absorb calcium because of GI issues like GI surgery or small bowel obstruction that can make it hard for the body to absorb calcium. Lastly, diuretics can cause calcium loss by dumping them out of the body and into the potty. So the body releases more PTH, which puts more calcium in the blood, because remember, PTH puts the calcium high. Next is R, for renal failure, which means low absorption of calcium from urine, which causes low blood calcium, mainly due to low vitamin D and high phosphorus levels. So the body has to release more and more PTH to put the calcium higher. And lastly is T for tumor. And write this down, this is a big NCLEX tip. Non-cancerous equals adenoma, and cancerous equals malignant tumor. So let's switch over to hypoparathyroid, which means hypocalcemia in the blood. Let's use the acronym HATER, because you know, hate is gonna hate. H is for hypomag, low mag. Remember, calcium and magnesium are best friends. So when one is low, the other is low too. A for autoimmune. The body attacks the parathyroids. T for thyroidectomy. Another NCLEX tip. This is what happens when we cut out the thyroid entirely and our little parathyroid buttons go with it. And lastly, R is for radiation, which could damage the parathyroids. Okay, and now for the treatments. Again, another simple fix here, guys. We're primarily treating the calcium issues first. Then we're gonna treat the causes. So, what makes hyperparathyroidism different than hypo is that it's the only one that can have surgery as a treatment. This is when we're gonna cut the tumor out or just take out the whole parathyroid, called parathyroidectomy. On the other hand, you have hypoparathyroid. There is no surgery that will help unless it involves a tumor. But most times, we just have to treat the low calcium disorder. All right, guys, that wraps it up. Thanks so much for watching.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to
Let's wrap up SIADH versus DI. Syndrome of inappropriate antidiuretic hormone versus diabetes insipidus. So in SIADH, we stop urinating and we get SI, soaked inside with low liquidy labs. And in DI, we diurese or basically drain a lot of fluid. So we get DI, dry inside, with high and dry lab values. Guys, a lot of NCLEX questions come from this. So it's important to know that it all revolves around ADH, the antidiuretic hormone. Created in the posterior pituitary at the base of the brain, our memory trick for this guy is ADH, adds to H2O. This guy keeps fluid in the body and not in the potty. Now the synthetic form of ADH, or basically the man-made or drug version, ends in pressin, like desmopressin or vasopressin. Guys, it's given to decrease urine output and also helps to press up the blood pressure. So guys, just think it's pressing on the veins. But caution, headaches are a huge priority since ADH adds to H2O. Guys, our labs end up low and liquidy, leading to hyponatremia, that low sodium, below 135. We're talking swelling in the brain, leading to seizures and then to death. So the big NCLEX keyword here is headaches, guys. Write that down. Or even confusion or agitation. Usually those are the first signs of that low sodium, hyponatremia. So let's break these down one by one. For SIADH, just think C for Spanish, which basically means yes. So yes, ADH, yes, add the H2O. So the body gets really soaked with fluid. Now guys, this is super simple. Just use our memory tricks, the 7 S's for SIADH. Our first S is for stop urinating. We get low urine output. And this means sticky, stinky, and thick urine. This means keyword high urine specific gravity, guys, over 1.030. This means we've stopped urinating, so whatever does come out is thick like paste. Now think SI for soaked inside, or basically swollen inside. We get really low liquidy lab values with keywords here, hypo or low serum osmolality, and hyponatremia or low sodium. Guys, always huge NCLEX favorites, write those down. So again, the NCLEX is gonna try and trick you. So SI, think soaked inside, guys, low liquidy labs. Keywords again, decreased blood serum osmolality and decreased sodium below 135. Next S is again for our NCLEX favorite, guys, sodium that is low. I'm gonna keep on harping this because the NCLEX loves to test you on this. So swelling in the brain with cerebral edema and seizures and death. Often the earliest signs, big NCLEX keyword here, guys, headache, 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 but also confusion and agitation. Next S is again for seizures from that low sodium. So guys, we set up seizure precautions for SIADH with that low sodium, huge priority. Next is for severely high blood pressure. Since SIADH, we stopped urinating and now we're swelling inside, guys. Blood pressure will be up as well as edema will be up. Which brings us to our last S, guys. We stopped urinating out, so we stopped fluid in. Now that's pretty simple, right? But the key word here, guys, is that we add salt to prevent those seizures from that low sodium. So we'll stop all IV fluids except if we need to give that 3% saline or that sodium chloride via IV. And lastly, we can always give diuretics to drain that slowed fluid-filled body. But guys, that didn't even come up once throughout the 10,000 NCLEX questions we surveyed to build this script. So diuretics are probably not a main intervention here. Okay, now switching gears here, let's jump over to DI, or diabetes insipidus. So the memory trick for DI is die, ADH, die. Guys, ADH is dead, so we can't add to H2O. The body ends up urinating like all over the place, peeing like a big circus elephant. So guys, this is super simple. The patient in DI will just look very dehydrated. And literally the exact opposite of that swollen SI-ADH. So guys, remember the 7 Ds of DI. So DI, think diuresing or draining fluid with high urine output. Guys, up to like 20 liters at a time. So we get very diluted urine, so very low specific gravity. Less than, keyword here, 1.005. That's a huge NCLEX term. We saw this a lot. So think about all that urine coming out, guys. What's happening on the inside? Well, yeah, you're getting dehydrated, so high and dry labs. So guys, think DI for dry inside. High dry labs here. So NCLEX keywords, write these down. Hyper or high blood serum osmolality, and hypernatremia, that high sodium, over 145. Guys, big NCLEX number right there. Again, they're gonna try and trick you. So again, DI, dry inside, high and dry labs, very thick, pasty blood with increased sodium and increased blood serum osmolality, basically meaning you're gonna have really thick blood. Now the next few Ds, we drink a lot of water, guys. Patients are gonna have increased thirst. You also have dry, dehydrated bodies with dry mucous membranes and poor, sluggish skin turgor. As well as a big one here, guys, decreased blood pressure. Write that one down. Now our last D and another NCLEX favorite here, D for desmopressin, our ADH in drug form, also called vasopressin. So guys, remember this adds the H2O. It's ADH. So desmopressin, think it decreases urinary output and also increases blood pressure by pressing on the veins. Now, a huge caution here, guys. It causes death, again, from that low sodium. So remember, since desmopressin decreases urinary output, it can also decrease sodium, causing deadly headaches, which again leads to seizures. Now the causes of SI-ADH and DI are very similar. Both revolve around damage to the brain. So guys, anything that puts pressure on the pituitary, since ADH is made in the pituitary. So for DI, remember D for damage to the brain, like tumors, trauma, and even brain surgery. This can cause increased ICP, or basically increased intracranial pressure, which squeezes the pituitary. Now the big difference from SI-ADH is the NCLEX keywords here, guys. Write this down. Small cell lung cancer and even carcinomas. And also ectopic tumors in the lung that secrete ADH. Our two other S's, again, are from brain damage. So severe brain trauma, like in DI, and even sepsis or infections of the brain like meningitis and even viral pneumonia. Now for nursing care in both conditions, guys, we strictly monitor I's and O's, both input and output. Basically meaning how much fluid's going in versus how much is going out. Now guys, this is huge since it will tell us if the drugs we're giving are working to correct the issue. So a great indicator is NCLEX keywords, guys. Daily weights, not weekly weights. Don't let the NCLEX trick you here, guys. Daily weights, since typically weight gain means water gain, and that really goes for any condition. So guys, if the patient is losing weight rapidly or suddenly, it usually means they're losing water rapidly or suddenly, or they're gaining it, vice versa. So guys, it's no bueno on the NCLEX. All right, guys, that wraps it up for SI-ADH versus DI. In this next segment, we're gonna be breaking down the top 4 missed NCLEX questions in this segment. So let's do it. What does the nurse expect to find in a patient with syndrome of inappropriate antidiuretic hormone, guys? Select all that apply. So before we even look at the options, look at SIADH, syndrome of inappropriate antidiuretic hormone, guys. I recommend to always draw out the little figure, the little fat dude. And guys, remember, we stopped urinating, so we have low urine output with very sticky, thick urine, high specific gravity. Also, if you guys drew out your little fat dude, we have soaked on the inside for SI, guys, low liquidy labs. So sodium's gonna be low, we're gonna have seizures. So let's look at our options here. Number one, we have low blood osmolality. Yes, guys, low liquidy labs, that's what we're looking for. Option number two here, increased serum osmolality. No, guys, that's DI, dry on the inside. We have low liquidy labs. Option number three, low specific gravity. No, guys, in SI we have very sticky, thicky urine, high specific gravity. Okay, what about option number four? Hyponatremia. Yes, low liquidy labs. And number five is also a yes, guys, decreased urinary output. Since in SI we stopped urinating. When caring for a patient in SIADH, what does the nurse expect to implement? Select all that apply. Guys, the keywords here is SIADH and expect to implement. So before we even look at the options, guys, the easiest way to tackle this is the S's in SI. I'd recommend drawing a big circle with arms and legs for SIADH. It shows that our patient is really swollen and stopped urinating. So let's recall the S's of SIADH, guys. We stopped urinating out, so now we have sticky, thick urine on the outside with high specific gravity. And guys, since we stopped urinating out, we stopped the fluid in. So we get swollen on the inside, guys, with low sodium as well as seizures. So let's select all that apply, guys. Option number one, IV maintenance fluid, guys. Normal saline? No, guys. We stopped the urine out, so we stopped the fluid in. We don't want to add to that swelling. Number two, fluid restriction. Yes. Since we stopped urinating, guys, we stopped the fluid in. How about sodium restriction? No, guys. We have low sodium in SI, very low liquidy labs. We need to add the sodium. Okay, how about option number four here? Seizure precautions. Yes, guys, remember the S's. We have seizures with that cerebral edema from that low sodium. And how about option number five? We monitor strict I's and O's, guys. That's definitely yes. Always for both SI and even DI. And lastly, if you chose number six, you are completely wrong. Measure weights weekly. No, guys, we're measuring daily. NCLEX will try and trick you guys. Weight gain means water gain, not weekly, always daily. A client with a brain tumor develops diabetes insipidus. Which data should the nurse expect to find? Guys, keywords here, diabetes insipidus and expect to find. Select all that apply. Now guys, before you even look at the options, always recall what the heck is DI? Well, DI, we're diuresing or draining fluid, guys, high urine output. So we have very diluted urine. And guys, in DI, we get dry insides. So high dry labs, and opposite of SIs, which we get soaked inside, guys, low liquidy labs. So the easiest way to tackle this is to draw a little stick figure and show that he's very dehydrated in DI. So let's look at our options here. Dark urine with high specific gravity. Guys, nope, that is not DI. We're draining out a lot of fluid. We get a lot of diluted fluid with low specific gravity. Remember, SIADH has the sticky, smelly, thicky urine. Option number two, how about high blood osmolality? Yes, guys, we get DI, we are dry on the inside. High dry labs. How about option three, weight gain? No, guys, DI, we're draining water, so we have water loss. We get weight loss. Option four is correct here, increased thirst, because DI, we get dry, so we have draining fluid, guys, fluid loss. Option five, sodium below 135. No, guys, that's low sodium. DI, we get dry inside. High dry labs, so high sodium over 145. And guys, the last option is wrong. Urine output below 30 mLs, guys, that's the bare minimum. So we have high urine output, guys. DI is draining a lot of fluid. A client is newly prescribed desmopressin nasal spray. Which statement by the client indicates further education is needed? So guys, we're looking for the no-nos. We're looking for the wrong answers here. So which statement is wrong? So our keywords here are desmopressin and further education. Now a quick recall on the pressin, the ADH, which adds the H2O. Guys, write down the 4 Ds of desmopressin. So desmopressin is for DI, to decrease urine output, and also death by headaches. Always a priority, early sign of low sodium leading to seizures and death. So guys, we're looking for the no-nos here. Option number 1, frequent headaches are normal. Guys, no, that's wrong. The first sign of low sodium or hyponatremia that lead to seizures and death is a headache. So headaches are not normal with desmopressin. Remember, death by headache. Next, the drug is used to decrease my frequent urination. Guys, yes, desmopressin decreases urine output. How about, I'm glad this drug's able to treat my syndrome of inappropriate antidiuretic hormone? No, guys, this is a wrong answer, so we're going to choose it. Desmopressin for DI, guys, decreases urinary output. Remember the triple Ds. Next one, I will record my output closely. Guys, yeah, we always record our I's and O's, input and output. And the very last one, guys, I'll weigh myself weekly. No, guys, we're weighing ourselves daily. Weight gain is water gain.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz.
All right, guys, let's wrap up hyper versus hypothyroidism. Guys, the easiest way is to let the name help you. So think thigh in thyroid is like a thigh master. You guys use a lot of energy since the thyroids create high energy and high metabolism for the body. So guys, in hyperthyroidism, think high energy and high metabolism. Now this is also called Graves' disease. So we call it Gaines' disease, high and hyper energy. Now on the other side, for hypothyroidism, guys, we think low and slow energy. So start moving your thighs during the exam. For hyper, we have high energy, and for hypo, we have just this low and slow. All right, guys, now a little bit of pathophysiology that the NCLEX expects you guys to know. But let's be honest, the NCLEX is never going to ask you a direct question about pathophysiology. So as you know, just like all endocrine hormones, it's a big game of telephone, or dominoes if you will. So the hypothalamus releases TRH, which then tells the anterior pituitary to release TSH, the thyroid stimulating hormone. And can you guess what the thyroid stimulating hormone does? Well, yes, guys, it stimulates the thyroid. Oh, how stimulating. So once stimulated, the thyroid pops out 3 most important key players, guys. Our T3 and T4, which are basically our active thyroid hormones. And also calcitonin, which basically puts a ton of calcium into the bone. So our memory trick is it tones down the calcium in the blood by putting a ton of calcium into the bone. So calcitonin, a ton in the bone. Now our thyroid hormones T3 and T4 are the main focus for our thyroid conditions. Hypo, we have low T3 and T4, and hyper, we have high T3 and T4. And to make this, your body needs dietary iodine found in salt. So iodine deficiency is a major cause of that hypo-low thyroidism in developing countries. So what causes our high T3 and T4 in hyperthyroidism? Guys, the number 1 cause is our autoimmune disease we talked about, Graves' disease. We think Gaines' disease in high thyroid. But also too much iodine means too much thyroid hormone. And even treating hypothyroid conditions, guys, if we give those patients too much thyroid meds, like levothyroxine, which leaves too much thyroid hormones in the body, we can eventually cause a hyper condition. So guys, balancing these 2 conditions is kind of like a teeter-totter, or basically like a seesaw. Hyper will be the exact opposite than hypo. So low T3 and T4 in our hypo comes from that autoimmune disease, guys, called Hashimoto's, that low and slow thyroid. Now, other causes are low iodine in the diet. And a big one, guys, big test step here, pituitary tumor. And even anti-thyroid treatments like a thyroidectomy, where we take out that thyroid gland and now the body can't produce any thyroid hormones at all. Now, as far as diagnostic tests, guys, don't let the NCLEX trick you here. So here's a tip. Always focus on T3 and T4 first. Guys, don't even look at TSH initially. If T3 and T4 are high, then it's hyperthy. And guys, if it's low, then it's hypo. Now, you don't have to memorize any of the values. The NCLEX will give you the ranges. Okay, now after seeing T3 and T4, then we look at TSH. So TSH will always be the opposite of T3 and T4 here. Guys, TSH is just trying to slow the hyper and amp up the hypo. So guys, as far as signs and symptoms, it's super simple. Everything in hyper will be high and hot, and everything in hypo is going to be the exact opposite, guys, low and slow. So for hyperthyroid, guys, that Graves' disease, our Gaines disease, everything is super high. We're going to be bouncing off the walls, super amped up like you're on a bunch of energy drinks. And again, the priority is to monitor for this thyroid storm, aka thyroid toxicosis. Guys, this will kill the patient. Again, NCLEX key terms are agitation, confusion, and even restlessness. Those are usually the first signs. Coupled with extremely high temperatures over 105, high heart rate, and blood pressure. Now, classic signs that will show up on Select All That Apply questions, guys, we use our 2 G's for Graves' disease. So the first G is for grape eyes. Now, the NCLEX term is exophthalmos. Guys, these are big eyeballs that are popping out like big grapes. So think exo and exophthalmos as eyes exiting the body. So typically we use an eye patch or even tape down the eyelids for sleeping, guys. That's always on the NCLEX. I know it's super weird, but always an NCLEX key term. And our second G is for golf balls in the throat, called a goiter. Guys, this will look like a big bullfrog looking throat. And now everything else will be high. So we'll have high blood pressure, aka hypertension. Remember, over 140, the heart says, oh lordy. We'll also see high heart rate, guys, known as tachycardia, over 100. Heart palpitations, we'll even see atrial fibrillation. Now we'll also see high weight loss. And guys, the NCLEX will try and trick you here. No, we're not talking about weight gain. The biggest thing is weight loss. So we'll see skinny patients. Since we have high energy burn, we burn a lot of high calories. Now with that, we'll have high hot temperature. Hot and sweaty skin known as diaphoresis. Guys, not dry skin, sweaty skin. Now this is also called heat intolerance. You will definitely see this on SATA NCLEX questions. And the very last thing, we have a high GI, so we get diarrhea, not constipation. So guys, patients in hyper mode need a hyper diet with high calories. Also high protein and carbohydrates. Now, big key word here, frequent meals and snacks, like 6 to 8 per day. Huge NCLEX key term. And guys, we also do the 3 big no-nos for the NCLEX. No high fiber, we need low fiber, unless the patient's constipated. Also, no caffeine, so no coffees, sodas, or teas. And lastly, no spicy food. Okay, now on the other side, in our hypo, our Hashimoto's, guys, everything is low and slow. So super depressed, fat, and lethargic. So we get the exact opposite from hyper. Again, the extreme priority is the extreme low and slow, airway, breathing, and circulation. Now the key term is myxedema coma, guys, extremely low respiratory rate. So we think respiratory failure. Again, the priority is intubation supplies at the bedside. NCLEX keyword here is endotracheal intubation set or tracheostomy setup. So we're expecting extremely low BP, aka hypotension, extremely low heart rate, known as bradycardia, below 60, and even low temperature called cold intolerance. Now the NCLEX tip here is no electric blankets, guys. This can actually harm the patient if they're not closely monitored. Now 2 more NCLEX tips, which are the biggest risk for myxedema coma. Usually after a thyroid removal, like a thyroidectomy, or abruptly stopping thyroid replacement hormones like levothyroxine. Usually those 2 lead to the myxedema coma, the extreme low and slow. Now classic signs for our hypothyroidism. Guys, everything's gonna be low and slow. Now these will show up on SATA Select All That Apply questions. So guys, just think everything's gonna be low and slow. We have low energy, known as fatigue, weakness, muscle pains, and aches. Low metabolism, meaning we have weight gain and water gain. There will be edema in the legs and even under the eyes. Now, the big key word here is not weight loss. We have low energy, which means low calories burned. So guys, we have weight gain here. We also have low digestion, called constipation, not diarrhea. Low hair, or basically hair loss, called alopecia. Now guys, this is not hirsutism. Huge NCLEX tip, they're gonna try and trick you. Hirsutism is that hairy suit. We have hair loss here. We also have low mental status, or basically forgetfulness, low mood, known as depression, apathy, or confusion, low libido with low sex drive or infertile, and also slow, dry skin turgor. Huge NCLEX tip here, guys. Not hot, not sweaty, hypo, we have that dry skin. Now our last two NCLEX keywords for low and slow. This is what's called irregular menstruation, guys. So we have no periods, or basically a missed period. So for a no period, it's called amenorrhea. So just think amen, no period. Now for low but heavy periods, we call it hypermenorrhea. So just think hypermenstruation, heavy bleeding. Now for diet and hypo, guys, we have low energy. So we need low calories, low cholesterol, low saturated fats. And since we have low energy, we need frequent rest periods, guys. Huge NCLEX tip right there. Now guys, the most common NCLEX questions revolve around priority, or basically who dies first. And it's always the extreme conditions, guys. For example, you will get a question about a client in Hashimoto's with that low heart rate, less than 60, or those low respirations, about 10, right? So we're thinking here, myxedema coma, guys. We put that intubation tray or the endotracheal setup near the bedside. So on the other side of things, you get a question about a client in Graves' disease, guys, with high heart rate, like over 100 beats per minute, or high blood pressure, over 140 systolic, and even high temperature, like over 101. Guys, the biggest thing, think thyroid storm, and the priority here is to monitor for agitation and confusion. Now, pharmacology and surgeries, always NCLEX favorites here, guys. Guys, grab your notes, grab your study guides that we provide. We're gonna be covering only the highly tested NCLEX topics here. So meds for hypothyroidism. Guys, we only have one main drug that you need to know for the NCLEX and for your nursing exams. It's called levothyroxine, which leaves T3 and T4 in the body. So guys, think levo we give for hypothyroidism. Now our second memory trick for those SATA questions is just the acronym LEVO. L for lifelong drug, guys. We never stop taking this drug. These are what's known as forever medications. And L for long, slow onset, usually 3 to 4 weeks till we find relief. Now test questions love to ask patient education on these 2 points, so I'd write those down. E is for early morning and empty stomach, always 30 to 60 minutes before breakfast, 1 time a day at the same time every day. Guys, never at night, always in the morning when you levantate, or basically get up. Now V is for very hyper, guys. We report signs and symptoms of hyperthyroidism. Basically high heart rate, high BP, high temperature. It could lead to an extreme condition known as our thyroid storm. So keywords we're looking for are agitation and confusion, usually the early signs of a thyroid storm. And lastly, O is for, oh, the baby's fine. So guys, it's pregnancy safe. Now the 4 most tested no-nos to help drive home the point for the most tested points here, guys. No food, we take an hour before breakfast. Keyword here is empty stomach. No cure, this medication is a hormone replacement. It will never cure, it'll only treat. So yes, this is a forever drug. And no double dosing. If you ever miss a dose, guys, take ASAP or as soon as possible. And lastly, never abruptly stop taking medications. Keyword is abrupt stop. It can lead to an extreme hypo, low condition with low respiratory rate, low BP, and guys, that will kill your patient. Again, this is called myxedema coma. Now, some common NCLEX questions that will try and trick you guys. It's going to give you SATA questions. For example, additional patient teaching is needed when the patient on levo says it doesn't work after 18 days. Guys, teach it's a slow onset, 3 to 4 weeks, like 21 days. Now the patient 30 weeks pregnant, guys, is that okay? Yes, it's baby safe. And my personal favorite, patient states, I'm glad this med will finally cure me. Guys, no, there's no cure here. And a little side note for hypo, since everything is low and slow. We avoid narcotics, or basically opioids, like Vicodin and other painkillers. And guys, we avoid benzos, which are sedatives. These drugs can actually add to the low and slow, dropping us into low condition, that myxedema coma. Okay, so now the pharmacology for hyperthyroidism, that Graves' disease or Gaines' disease. Guys, think here. The thyroid is super amped up and super high. So we need to slow down that thyroid, right? Or basically, we need to kill it. So the 4 drugs you need to know. Methimazole, guys, is not baby safe, but its friend PTU, propethyluracil, memory trick for PTU is puts the thyroid underground. This guy is baby safe, but we report fever and sore throat. Guys, these dudes stop the thyroid from making T3 and T4. Basically slow it down. Now SSKI, or potassium iodide. Guys, the memory trick is SSK. S for shrinks the thyroid before thyroid removal, or basically thyroidectomy. This is done to reduce the bleeding, aka reduce the vascularity. S is for stains the teeth. So guys, drink it through a straw with some juice. And K is to keep it 1 hour apart from other anti-thyroid medications. Lastly, since hyperthyroid, we have a hyperheart, we use beta blockers, which puts the brakes on the heart, slowing it down. Now these guys end in LOL, like propanolol. So think the double L's in LOL lowers the double heart vitals, so low blood pressure and low heart rate. Now next up, guys, the most dangerous and consequently the most tested here. RAIU, radioactive iodine uptake, guys. These are the big guns. It destroys the thyroid in like 1 dose. So we expect hypo low signs and symptoms. Basically, we're monitoring for extreme lows like respiratory failure. Now again, guys, it's very toxic, making the patient like radioactive. So some common NCLEX selected apply questions always come from this section, guys. Write these down. Before giving, we always ensure a pregnancy test is negative. We always remove neck jewelry and dentures. That one came up a lot in the NCLEX here. And 5 to 7 days before giving this drug, we hold any anti-thyroid meds. And guys, yes, you're awake. There's no anesthesia. There's no conscious sedation. So we're just NPO 2 to 4 hours before and 1 to 2 hours after, guys. It's not 12 hours and it's not surgery. This is just a radioactive pill. 1 dose, 1 and done, lasts about 24 to 72 hours. And speaking of after we give it, guys, we avoid everyone up to 7 days. Now, most quiz banks say about 1 to 3 days. So just avoid everyone. So no going around pregnant people, guys, no crowds, not even the same restroom. We're flushing it 3 times. Not even the same food utensils, guys. And no, not the same laundry as your family, separate laundry baskets. And lastly, no cuddling and not even kissing. Now lastly, guys, if all else fails, we can do a good old-fashioned surgery known as a thyroidectomy. Now a lot of NCLEX tips come from this section, so please write this down. Since thyroidectomy are usually done for hyperthyroidism, it's kind of like removing a big glass of milk. Surgeons can accidentally squeeze out a lot of thyroid hormones into the body. So guys, we're monitoring for high extreme conditions after surgery, known as a thyroid storm. Okay, now for the big NCLEX priorities, we have the ABCs of thyroidectomy. A is for airway. Since surgery is done near the neck, guys, we think airway. Huge NCLEX key terms here, write these down. Laryngeal stridor, noisy breathing, and even hoarseness or weak voice. Huge, big NCLEX key terms there. These usually indicate an airway problem, so the #1 priority is endotracheal tube at bedside. Now the NCLEX will call it different things like intubation supplies and even tracheostomy setup. So anything with the word trach in it, guys, keep it at the bedside. Huge on the NCLEX. Now B is for breathing that is noisy, like covered before. Laryngeal stridor. So guys, we always monitor voice strength and quality. Now next, C is for circulation. Obviously, we just had the surgery, so guys, we're looking for bleeding, but specifically bleeding around the pillow and insertion site. Now, big NCLEX key terms for positioning to prevent the bleeding, guys. Write these down. We want a neutral head and neck alignment. This means not supine. Big no-no, guys. Head of the bed, 30 to 45 degrees, aka semi-Fowlers. And lastly, guys, big no for flexing. This is a no flex zone for sure. No extending the neck, huge and always on the NCLEX. Now our last C, which is another NCLEX favorite, guys, calcium that is low, below 8.6, known as hypocalcemia. Now guys, these numbers are based on NCLEX standards, so your textbook and your school might differ. So memory trick is if you remove the T, then you check the C. Or basically, if you remove the thyroid, then guys, check the calcium. Now the first sign of low calcium, write this down, tingling and numbness or circumoral tingling around the mouth and even the fingers. And the two other keywords are T and C for low calcium. So Trousseau's, which is basically that arm torque with the blood pressure cuff on, and Chavostics, that cheeky smile with facial numbness. So guys, I call these the two dance moves of low calcium. So remember, if you remove the T, then check the C.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate and even your instructor. See you guys in the next videos.